about nursing assessment. We just really quickly going over this from yesterday. So we talked about we're doing nutrition, right? How we get their history. What are we going to see? How do we assess them to find out if they have certain oxygenation issues? We look at their nutrition, their hydration. We look at their stress and coping. Are they anxious? Are they something happened to them that caused them anxiety that can cause breathing issues. We talked about respiratory history. Have they had a cold, a flu, pneumonia, COPD? We talked about medication. Which medications are they on? That'll tell us that they have some kind of oxygen issues. Are they on albuterol, corticosteroids? Then we look at their lifestyle. Are they sedentary? Are they very active? Right? Then we talked about the risk factors. We said genetics. There are some diseases that allow someone to be more prone to having certain respiratory issues. We talked about cystic fibrosis, where the mucus is plenty, and so that's one of those things. We talked about sickle cell anemia, where the blood cell can't roll down because it's in the S shape. It gets clumps. That can cause oxygenation issues. We talked about age. We said the little babies, their lungs are not very well developed, so if they have lung issues, it's probably because something happened, whether it's their heart or their lungs, there could be a problem. Their age related to older adults, we said everything is relaxing, and so that activity of breathing can be affected as well because of that. Lifestyle connected to risk if they're sedentary, kind of mentioned that already. Certain activities can trigger it, like if a child plays sports, then you kind of tell them, it's going to trigger it. So we want to make sure that they take whatever medication that they need. We talked about gender. We said men have hemoglobin that are a little more plentiful than women. And that's why that controversy between transgender playing in other sports, they feel like it's unfair because there's a difference in their anatomy and makeup, right? Now we started talking about inspection. We started saying, how do we identify these people? Just by looking at them. We said skin color. We talked about, what else did we say? They would look fatigued, right? A few other things, they might look pale. They might turn blue, cyanosis, we mentioned that. We talked about the diaphragm, the barrel chest, right? So now we're up to palpation. So let's talk about what would you see if you're palpating someone who has an oxygen issue. So this one's a little odd. Yes. Crepitus, right? So crepitus is a grating sensation that is produced by friction, bone, and cartilage. It's rare. Actually, last quarter, someone felt it under the chest, right? The chest wall, they were feeling it. It was like, it's a really funny, weird it's a funny feeling when you feel it, because you don't expect it, right? So that's the palpation. So the next one is percussion. What are we percussing? Why when we percuss, what would it indicate to us? Fluid fill, but how would we know? What does that mean? Solid. Okay, so it's the sound, right? So when you percuss, like, you know how when you're trying to nail in something into the wall, right? That's how sometimes we hear it. We knock, and wherever it's hollow, there's no beam there. Right, so the same thing, solid. If it's all tissue, it sounds differently than if there's air, right? So then we know there's something going on there, right? If it's filled with fluid, it'll sound more different than if it's air, as it should be. So yeah, that's percussion. What's another mentioning of percussion that we talked about? This is assessment, but just because we're on percussion, what's something that we do to help them as an intervention that seems that has to do with percussing?
What did you call it?
Yeah, chest PT. It's not exactly chest percussion, because percussion is more like this, right? But just the idea of tapping, right? We are patting their back to help the movement up. And we'll talk about that more when we talk about intervention. This is just assessing, and it just came to mind when I thought about percussion. Okay, so let's talk about auscultation. That's the biggie, right? What are we going to hear when a person has, oxygen issues? What are we going to hear? Let me see if I can bring this to see. No, anyway, you just watch me. Wheezing, right? We'll hear the wheezing sound. What else? What other noises do we hear on auscultation? Crackles, right? We hear crackles. We're going to learn about, so when we learn about asthma, we'll hear the wheezing. When we learn about pneumonia, we'll hear the wheezing there as well. What other things could we hear? What other sounds are there? Stridor. Did you say it at the same time? Knock on wood. I'm kidding. Yeah, stridor. There's rhonchi. Okay. Whooping. You know what that one is with? Which disease that is? Whooping cough, right? There's a pleural friction rub. You can hear that as well. And there's a mediastinal crunch that you can hear. So those are, I know, I haven't heard that one to be honest, but it sounds funny, just like the crepitus. Yeah. So yeah, those are the things that you would do in order to, how you would assess to see, right? But then there are other things we didn't mention, right? When we are, what other things haven't we mentioned that's part of assessment? Oximetry, pulse oximetry, right? We want to take the pulse oximetry to see. Okay, let's talk about diagnostics, okay? So these are the things we're going to use in order to identify which one. Like, this is how we kind of differentiate. Is it oxygen? Is it asthma? Is it, tuberculosis? Is like, we have all these respiratory issues, but which one is it and how are we going to treat it? Because depending on which one we find, might be a different treatment, okay? So there's a sputum culture. What's a sputum culture? Yeah, you spit, right? And the funny or interestingly enough, it's not just spit, it's actual, they differentiate, yes, spitting from sputum, because spitting comes straight out of your mouth, whereas a sputum comes from a deeper space inside your lungs. So you have to cough in order to bring that up so you can bring up the bacteria. Right? And a lot of times you want to rinse the mouth so that the spit doesn't have other bacteria from eating or whatever that's going to cloud the judgment as to what kind of bacteria it is, right? And you want to do it what time of the day? Morning. In the morning, exactly. Okay, so what else? Then we have ABGs, which we will talk about later. So ABGs are what? Yes, arterial blood test. And what that is it's going to identify what the carbon dioxide from the, or it's going to identify how much carbon dioxide the person has, which is going to help to identify, is it respiratory acidosis, metabolic acidosis, or is it respiratory alkalosis or metabolic alkalosis. So, but because we have respiratory acidosis, that can also tell us if it's there. Okay, then how do you do ABGs? Where do you draw it? It's an arterial blood. Yes, so it's the ulnar, right? So, and there's a test that you do in order to make sure that that artery is viable, that you can use it. Do you remember what that test is? It's called the Allen's test, right? So they put a blood pressure cuff, squeeze it, right, and then when they release it, right, they it's not necessary. It doesn't have to be a blood pressure. They could kind of like hold down the artery to make and once they let one go, they'll see if the blood flushes to the hand, or if the blood flushes, that means that artery works. Then they'll do it again, hold down the other artery, let go, and if the blood flushes or your hand flush with blood, that means it's working. But if it's pale, once they let it go, that means that artery is not very good, right? So that's the Allen's test. Then we have the pulse oximeter, which we already mentioned, which is different from oxygen saturation within the blood. So that's when you just put the little probe on the fingertip, on the earlobe, on the toes, depending on where you have access. Okay, you have PFT. What's that? Pulmonary function test. So that is when you do all these different little tests all together that helps us identify how much vital capacity, how much expiration, how well the lung is working. So that's done by a pulmonologist, right? They have this little machine, they make you blow, 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 and you're like, I can't blow anymore, right? And a lot of times for people who are even healthy, it could be hard, let alone those who are not healthy and their lungs are damaged, right? So, but it does definitely allows them to see how well the lungs are working, and whether they have asthma or any other lung disease, it will identify if there's an issue there. Then we have the peak flow meter. What's the peak flow meter? The peak flow meter is the one that most asthma patients are asked to use to see where they are and how well their medication is working, right? So it has yellow, green, and red, right? It's just like the lights. So if you are in green, right? I should say green, yellow, and red. If you are in green, that means your medication is fine and your lung capacity is great. You're good to go. Keep taking your medication. You're fine. If it's in yellow, it means there might be an issue. You might consider changing your medication because it's not working as well as you would like, and the capacity is less, right? So it's like for green, it's like 100%, right? 85 to 100%, and yellow is like less than 85. And then we have the red, which is like 60, or, like this is not great. You need to get help now. And within the day, if you don't get to the emergency room, you might have an attack. So it's definitely necessary for you to get to the emergency room because it's a big problem. So in the, just to mention, in the FPT, we also have the, what's called a V1. So it measures all these other measurements that tells us how the lungs are doing. I just wanted to mention that. Okay. Then we have the chest x-ray. Why do we do chest x-rays? What do you remember from previously, the reason behind chest x-rays? What are some examples? We do chest x-rays because, or to check what? TB, yeah. So we want to make sure. So we're not covering tuberculosis, but when you do, you'll find that it's a pus, right, that's being built. It's a bacteria that grows in whatever area. And it's not only in the lungs. It could be anywhere. But in the lungs, it grows, it grows, it grows, it grows. And whenever there's fluid somewhere, it shows like a shady area. So if you find it in the lungs, that's what it means. And that shady area, when you think about abscess, right? If the abscess is there, beneath the abscess, there's no life, or it's not very viable because that fluid is pressing on the skin, right? And it's going to damage that area because of the pressure. So then they're imagining that whole area might be damaged, right? And it might not come back, but it'll tell us that there was some damage there. Does it mean that the person has tuberculosis? No, right? It might not be active. It might have been from previous damage. That's why you have to do a sputum culture. The sputum culture for tuberculosis is what tells you have active tuberculosis, the fast bacilli, positive bacilli, right? They actually see the creatures, bacteria growing under there. But yeah, chest x-ray to see if there's fluid in there, What else? We have the VQ scan. That one, it tells us the ventilation versus the perfusion. How is it working? Okay, so it's a nuclear medicine scan that uses radioactive material to examine airflow and blood flow in the lungs. Then we have the bronchoscopy. Bronchoscopy does what? It sends a camera into the lungs to see how things are. Are there any abscess? Are there any polyps? Or are there any growth? Like what's causing the person not to breathe properly? If they suspect what? Usually if they suspect cancer. There are other reasons as well, but just when they find a problem and they can't identify what it is, they want to look at it, that's what they'll do. Okay. What about thoracentesis? What is that about?
Draining fluid.
Yes, draining fluid. So when you studied fluid and electrolytes, we identify that fluid shifts into interstitial spaces, but they can also shift into cavities when they're too much. If they're in an interstitial space, then movement, shifting the body, lifting the arm, lifting the leg, putting, the extremity on a pillow, whatever, right? Brings the fluid back, makes it go back into its space. But with a cavity, that can't happen. So with edema, when we change positions, we can return fluid back into the space it belongs. But with cavity, that can't happen. With a cavity, you have to manually go in and take it out. That's called third spacing. So that's an example. So the cavity where the pleural sac is, if it's filled with water, filled with pus, filled with whatever, we can't get rid of it just by changing position. So you have the person lean over or a Sims position, and then we put a needle in there and then we aspirate. The most important thing to realize is you can't pull out too much, because anytime you're pulling out fluid, whenever you do so, wherever the space, you only can pull out 1,200 cc's so that the body doesn't feel as if it's losing too much and go into hypovolemic shock, right? So thoracentesis, we need to get that done. Yeah, so these are all the diagnostics that we will do in order to identify what the problem might be. Now let's talk about interventions, which we've covered, right? So this is kind of a review. So how do we improve nutrition? What do we do to help improve nutrition? That's an intervention. Cluster, right? We want, okay, cluster in the sense of how? Tell me.
Like if because they're more than likely going to be fatigued.
Yes. So we want to make sure whatever activity they've done, we want to give them time and space so that they can rest and then do certain activities, including eating. Make sure they were well rested before you give them a meal to eat. When we do give them a meal, what kind of meal is it going to be? High calorie, because it takes some time to eat. So when they do eat, you want to make sure that it's packed with calories so that if they don't decide to eat again for a little while, they are able to sustain themselves. Okay, but definitely make sure that they are eating. Now, if they do eat, can they sit and eat a huge meal? No, they get too tired. So you want to do what? Small, frequent meals, right? And we say frequent even though we're like, wait, but aren't we supposed to be clustering? Aren't we supposed to not bother them as much as you can? The point is, don't give them too much at one time because they won't be able to manage it. We want to administer medications. Which medications did we talk about that we're administering? Albuterol. So and the other one is corticosteroids. Which one do we give first? Albuterol. Why?
Open up the way for
yes, we want to pop it open to make sure the air goes through now because it's called a fast-acting drug, right? And then we want to give the corticosteroids afterwards because what does that one do? It keeps the what down? Inflammation down. So you want to keep the inflammation down and you want to keep it down for a long period of time. So when we get to asthma, we'll see the reasons behind that. Inflammation is bad and it's bad for everything. Even though we need it, it's part of the process. It's kind of like differentiation, right? It's a necessary evil, okay? We need it, it must happen, but there's problems when it does. And we'll talk about that even more. So definitely we want to keep inflammation down. Then we want oxygen. And so wait, let's go back to corticosteroids. So in the pump, right? Let's say they use it in a pump. That was it, HFP, right? They use it in the pump. What do you tell them to do? Wash the mouth. Why is that?
Because it can cause thrush.
It can cause thrush. So that's one of the things that you want to make sure that you let them know. And when a person is on corticosteroids, can they stop it abruptly? No, they have to wean them off. Wean them on, wean them off, right? Okay, oxygen administration. Who are we giving oxygen to?
People under 95%.
Right. So anyone who's 95% or below, or that we see needed. Because of one person's 95 is not another person's 95. It depends on them. And that's the same idea when we talk about diabetes, right? Where like a person could be 60 and they're fine. But another person is 60 and they're sluggish and they're low. So you have to, 95 is your key point, right, to see. But if someone is, let's say 96 and they are 97 and they look like, then you want to give them oxygen, right? So, but 95 is the thing that tells us, this is not a good space to be. Let's get the oxygen close, right? Who don't we rush to give oxygen to if we find them at 95? COPD, right? We want to look to see how they're faring, how they're managing, right? So their lowest could be 93. I've seen patients 93, 94, and they're fine, right? But I've seen patients also 93, 94, and they're like, they need oxygen. And what's the thing? We have to give them precise oxygenation, right? So there's this mask called Venturi mask that gives you, it calculates the oxygen that it gives a person in order to make sure it's precise, that they're not getting more than they need, okay? So definitely giving them oxygen. So now, how would I know to give someone oxygen? Like, it's the numbers, right? So always remember, anytime you find someone in distress, the first thing you want to do, if they tell you the person is already in distress. There was a question on the exam that mentioned the distress. Distress means what?
Not having a good time.
Right, like distress is bad. Distress is going to be like you're going to end up in the emergency room, right? It's not good. So if the person is in distress, whatever intervention you're going to do has to be immediate, and it has to, sometimes you're even skipping, raising the bed. You're skipping the non-invasive stuff because that distress is going to kill them, right? So when you come and you find a person, let's say, who needs oxygen because they were doing an activity and you already measured, you already assessed, and you see they're in distress, are you just going to stop the activity, or are you going to deliver help? Right? You're going to get the help that they need, right? You're not going to allow them to gradually go back to, let's stop now. No, you're going to give them oxygen, okay? Because you don't want them to get further and further in that distress mode. Okay, let's talk about deep breathing exercises, right? What are we doing that for?
To make sure they still have their lung capacity.
Yeah, we're exercising the lungs in order to help it to come back to its normal activity, normal capacity, to expand it. And which device would we use to do that? Incentive spirometer. It's important that you teach your patients how to use it, right? You don't just put it on the table and just like, this is what you do, right? You show them, you put the device within your mouth, you take a deep breath, then you blow, you watch a little ball go up, and then that tells you that it's working well, okay? You want to position them. Why are we positioning them?
To alleviate the lung space.
Yeah, right? So the biggest problem with, let's say pneumonia, it's surface area. When they lie flat, so when I stand, my lungs are like this. So if I have fluid in my lungs, the fluid will be at the tip. So the place that it's covering is not as much, right? Because it'll accumulate at the bottom. But once I lie flat, right, then all the fluid is occupying more surface area. So more alveoli will be underwater, and I will feel it even more. That's why patients who can't breathe because of pneumonia, they're always trying to get up. And I had a story, one of my students was telling us at clinicals that I think he was an EMT, and he went and he was either taking someone or he was leaving, and he saw someone. Anyway, the guy was trying to get up, and they thought he was being combative. But he wasn't being combative. He was just trying to breathe because he was too flat, and he needed to get himself up so that he could breathe better. Right? Same as the COPD, when they're leaning over, right? It's or even heart failure patients, when they're leaning over, or they need multiple pillows in the back, they can't lay flat. It's all that surface area where the fluid is accumulating is too much, and they feel they can't breathe. So we want them to sit up. Encouraging smoking cessation, we know that, right? Whether it's because of emphysema or just their lifestyle, even before they have issues, we want them to stop. The thing about stopping, though, it's not, we have to be careful how we talk to people about stopping, because if they didn't like it, they wouldn't be doing it, right? So it's not just like, oh, you need to stop, and then they're like, okay, you're right, nurse, right? Like, they know that. They've seen, not even shows, or even shows, movies about people dying with cancer, or they've seen those little commercials. But it's a difficult decision. So you want to have a good conversation, an empathetic conversation. And usually we talk about what are the reasons behind why you would like to stop? What are the reasons behind why you're still smoking? And then we want to intervene that way. Oh, it helps me lose weight. It helps me reduce my anxiety. Okay, so let's find another reason, another way to lose weight. Or let's see how we can manage your anxiety, right? We want to have a deep conversation and not just hand them a patch and walk away, or berate them about why they know they shouldn't be smoking, right? And then we want to monitor activity intolerance. Why do they have activity intolerance again? They're tired because oxygen is energy. They don't have oxygen, they don't have energy. They can't do their thing, right? What kind of things can't they do? What's activity intolerance mean? What can't they do?
Depending on them.
Depending on them. So give me a few things.
Even standing sometimes.
Standing, right? From getting off the bed to the side of the bed to stand, they can't. But just sometimes sitting up in bed, changing position, you need energy to do that. They can't even do that, right? We already mentioned the eating, they can't eat. But what other things can they do? What do you do every morning? What do you do in your life that you need energy for? Taking a shower, brushing your teeth, putting your clothes on, brushing your hair, right? You see people, it's hard for them to even do the simplest things. Activities of daily living. It's hard for them, so we have to be careful with that. That's why we cluster the care, right? So assist with ADLs, showing them, okay, let's put your shirt on, we'll help you with that. Put your shoes on, brush your teeth, brush your hair, that kind of thing. We want to help them. Monitor secretion clearance. What are we doing with secretion clearance? Yes, right? Half coughing, cough, right? The same thing with the deep breathing exercises. We want to show them how to do it. What else? How else can we clear secretions? Hydrate, yes, we can definitely hydrate them because the secretions can be thick, and that's why they get stuck, and it's harder for them to bring it up. So definitely hydrate them. One more thing. Your skills lab is on trach, right? We want to suction them. We want to make sure that we suction them at least 3 times. We want to do it intermittently. We don't want to suction on the way down. We want to suction on the way up. We want to make sure that it's they're humidified afterwards because that hyperventilate. All the things that you learn about suction you want to do to make sure that they're able to clear the secretion. And sometimes they can bring it up, but they can't spit it out, right? And so then we do the yonker. So there are different things. And then the thing about suctioning, though, right? We know if a person is at home, they can do their own suctioning, right? But in the hospital, can they do their own suctioning? No, they need help, right? So when we talk about independent, these are things that they need to do by themselves. So, but the suctioning, they could do it at home if they're at home, but we always want to see where are they. If they're in the hospital, they can't do that by themselves. Okay, let's answer these questions really quick. Actually, you know what? Let's pass the questions. Let's go to end the case study. Let's go to today's lesson because that one is also important.